Greetings to everyone here at Einstein's Eyes, our YouTube channel. I'm Carl Rosen, oculoplastics neuro-ophthalmology in Anchorage, Alaska. I'm with my friend and co-host and former resident at Albert Einstein, John Ditkoff.
Hello, everybody. I'm a general ophthalmologist specializing in cornea. I've been in northern New Jersey now for 31 years after training, and I even got to work with Carl for 3 years at Albert Einstein. Hence, we named our website Einstein's Eyes, and we're glad you're tuning into our YouTube videos, and we're really excited about a new topic today.
Right. Today we're going to talk about limb lengthening, a surgery that can add inches to your height. And is it safe? Who qualifies? What does recovery really look like? Orthopedic surgeon, Dr. Kevin Debiparshad, is here, and we're grateful he's here to walk us through the science, the ethics, the outcomes. Let's get into it. But first, Kevin, if you could just tell us a little bit about your background and then jump into the procedure.
Sure. So, as you mentioned, I'm Dr. Kevin Debiparshad. I'm an orthopedic surgeon by training, and then I subspecialize in traumatic as well as limb reconstruction surgery, including limb lengthening surgery. And I'm here based in Las Vegas, Nevada. I also am the founder of the Limb Plastics Institute, which really kind of hones in on the cosmetic application of kind of what we do when it comes to limb lengthening surgery, as well as I still have a general practice where I do a lot of traumatic and limb deformity type adult reconstruction type work. So, it's a large bucket, I would say, right? So limb deformity, limb lengthening, changing the way a limb looks is a large bucket, right? Applications in pediatrics and post-traumatic reconstruction, in stuff around resecting bone from iatrogenic pathology, cancers, all kinds of different things. And then obviously this idea of cosmetics, right? So the idea of cosmetics has certainly been around well before me. I think, even in the 70s and 80s, you'll see publications with older type technology like the old Elizroth frame, which is an external frame. Just to explain that to the audience, there used to be the beginning of limb lengthening and deformity surgery was basically these pins that we would pin to your leg, and we put them on circular frames or some sort of external frame. So everything was on the outside, and be able to manipulate the bone like a joystick through guided sequences so that we can change in real time the geometry of the bone, as well as the length, shorten, all that sort of stuff. We would be able to move it in all planes essentially. That technology has since advanced, obviously, and we have now internal devices that can go inside of most long bones, not every bone, but most long bones. These then respond to remote control and allow the once procedure that we used to do to be a lot more palatable for patients to kind of go through the process. Hence, I think that has also jumpstart this idea of cosmesis, because it's become a lot more minimally invasive. It's become a lot more cosmetic. We put the implant in, patients can go back to work, pretty soon after the procedure. And in some cases, it can be, not even noticeable in some ways, except that you're slowly growing as you go through the process of limb lengthening surgery. So I think the advance in technology has helped to kind of push this idea of cosmetics in our field more, and it's our fastest growing market, actually. So every year we see the technology being used more and more for this percentage of the group. I don't want to talk too much, so cut me off whenever you want. But years ago, when this technology was part of NuVasive, which was a publicly traded company, their CEO came when they first inherited. They bought the privately owned company named Ellipse, and they flew here to see me, the CEO, and he was talking about what this technology could do. And I told him, you're going after, like, you built this $4 billion company or $5 billion company at the time, looking for 1 in 200 people that need that procedure or need something, right? It's a very small number, right? How many people need? They were a spine company, so how many people need a spine fusion, or how many limb lengthening or deformity surgery? It's a very small number within a giant population. If you take that same population, how many of those people could want to be taller, for instance? Right? When you start looking at it from that perspective, you start realizing it numerically. You think, okay, well, actually, maybe all of them, right?
Huh.
So
Yeah.
what type of company can you build if you built a multi-billion-dollar company on looking for one in 1,000 pathology if you could treat all 1,000 of those people, right? So, so I think that stemmed the idea of, them further developing the technology and some growth in the field. And I still think it's in its infancy, to be honest. I still think this field, once I'm in my retirement years, I think will have completely transformed. And I think it'll be the largest segment in limb deformity.
Give me the 30,000-foot view. What is
Mhm.
limb lengthening in 2025 and 2026? If you could also walk me through a patient's journey from making the phone call to your office to the post-op recovery room.
Sure. So more modern day, the pictures you're showing here depict both a femoral lengthening nail and a tibial lengthening nail, and both of those will respond to an internal device. So these technologies really have been around since the 90s to some degree. There have been some old European technologies that used various ways to lengthen the bone, and there was a ratchet system that required rotation of the limb to actually ratchet the bone as well. Now, the most modern, I would say, the most modern technology is a magnetic based coupling that we do to move the nail internally from an external remote control. And both these devices that are placed with an osteotomy, so you'll see there's a fine line at the level of the femur, a fine line at the level of the tibia. That's the percutaneous crack that we do in the bone. So a separation, or what we call an osteotomy. The nail is obviously placed between that crack and locked proximally and distally. So there's two screws you can see locking the top and the bottom of the nail. That nail will respond to remote control, which will slowly lengthen. Generally, in a femur, that could be about a millimeter or so a day. So it might take you about 25 days or just a little shy of a month to get an inch. And in the tibia, that's about 0.75 millimeters, about 3/4 of a millimeter a day. So it might take you a little over a month to get an inch of length. And that's really how it's done. The capacity of the nails that we currently have in the market are about 3.2 inches, approximately, about 8 centimeters or 80 millimeters. And so that's what patients can achieve. If patients are looking to go forward with this, there's a combination of ways that the patients can get a hold of us. They can, through social media, through email, through calling the office. All those work, and they usually will be triaged by someone in the office who can kind of answer a couple questions, maybe give them some brochures, maybe field any questions they may have initially. If they want to look more strongly at looking at doing this, then they'll generally do a video consult with me, or potentially an in-person consult if they're near Vegas or they happen to be in the Las Vegas area. And then we'll go through a more detailed kind of conversation about it, as well as if they're here in person, I'll do a physical examination as well as imaging, just to make sure that they're candidates for the most part when it comes to anatomy, as well as the examination is within normal. There's no sort of contraindications to moving forward with surgery. But in general, a lot of patients can be a theoretical candidate for this procedure. I mean, and they do remarkably well. I know it sounds somewhat barbaric, I'd say, like when you hear, because I'm talking to eye surgeons, right? So when
Yeah.
you're thinking about breaking the biggest bone in your body with like a mallet, and it sounds pretty, compared to the delicate work you do, but it really is percutaneous. It's really tiny little incisions. It's all fluoroscopic guided. Patients, for me at least, walk within 3 to 4 hours of the procedure. Usually keep them about 1 or 2 days as an inpatient. They're mobilizing throughout that process. I'll generally get them to drive a car usually by 2 weeks. They usually wean off. About 50% of patients will wean off pain medication by about 2 weeks. That number probably goes up to about 75 to 80% by 3 to 4 weeks. There's always a subset of patients that, as they go through the lengthening process, will take some pain medication. There's variability just amongst patients. But that's the overview of kind of how we kind of get it done and how we do it.
What are the contraindications to doing this?
Like a lot of other surgeries, and I'm sure you're probably the same mindset, but things like any sort of chronic disease that would be out there that would be poorly controlled, or would not make a candidate for an elective procedure, particularly elective cosmetic procedure. So controlled diabetes, or cardiac issue, or on certain medications that might prevent you from making bone and going through the process, increase your infection rate, that kind of stuff. So any sort of significant non-controlled chronic disease would certainly be a factor. Age for me used to be kind of one, though I have done a 70-year-old, and he did extraordinarily well. He was originally from the UK. We actually did a very big TV show together. It's like our version of the Today Show in the UK. He was originally from the UK, and
Oh,
he did very well. I think he's probably in his mid 70s by now. He lives in Texas. He was an architect. Did very well. Played around the golf before I took his implants out. Said he shot his best weekend ever, I think, in Arizona. So he did very well. I have some other patients. I think I have one coming up that's, I think, going to maybe break that record. I want to say he might be a retired anesthesiologist. So no one knows the risks more than he does, I guess. But he has no chronic diseases, and he's, past the age of 70 now. So that isn't necessarily a no, but it is a worth a long discussion to kind of go over, what you're kind of getting into, and what is entailed with the process, and what's on the other side as you kind of go through this. So, but those are kind of the main things. There can be some anatomic things if there's abdominal anatomy or something that could be a contraindication to moving forward, like some, dysplastic hip or some other changes that could be anatomic variations. But, even taking all that into consideration, there's still a giant part of the population that really is a candidate for it in some ways. And I got to say, I see patients from all walks of life. I mean, in the summer, we do a lot of kids. Their parents bring them. They can be quite young if they're squealing mature or just at the end of it. And then I've got patients, like I said, that are quite old, and they, at the end of their career. And I'm thinking, what do you want to do this? And so, but, they have just as valid a reason as the guy who's 14, to be honest. I couldn't argue. I mean, the patient who was from the one guy who I think I did him on his birthday, I think it was his 70th birthday when I did his surgery.
wow.
His wife was in the background. They have grandkids. And she seemed like a reasonable lady. So I saw her in the background on the Zoom call. I said, "Who's that lady behind you?" He's like, "That's my wife." I was like,
Sure.
"Oh."
Yeah,
I was
sure.
like, have her come over. I want to talk to her. I was like, you're gonna let this guy do the surgery." And I think they'd been married like 45 years or 47 years. And she's like, "Yeah, we've been married like 47 years. And, he hasn't asked me for anything yet. And this is what he wants." So I said, "Oh, yeah, that's a valid argument." So I said, "Okay, let's go ahead and do it."
So
I'm going to
Kevin,
dive in with a couple of questions.
go ahead, John.
Yeah.
They're quick ones. So just what you tell a patient, what's the success rate? Like what percentage of people are going to grow 2 inches or more, let's say?
Yeah, no, the success rate is actually quite high. With femoral lengthening, you can get, I would say, well over 90% or 95% of patients can get the full capacity of the nail, which is about 3.2 inches. In
Wow.
the tibia, it's a little trickier because the gastrocsoleus is a much more unforgiving muscle, and it's a much more fibrous tissue with a lot more, fascial tissue that will likely only get you to about 2 to 2.5 inches, somewhere in that range. But in combination, you can kind of get, close to that 6 inch plus. I've had patients who've even gone over 6.
Wow.
Um,
That's
but,
amazing.
but that's how much you can get. If you think about it, you can kind of do without surgery, right? Like if you wanted to do the splits, let's say John and Carl, you want to go do the splits, right? You can't do the splits today if I told you to do the splits. But if you worked hard and you quit this job, you quit doing surgery, you quit everything, you said, "I'm going to focus on doing the splits," and you work with a yoga instructor and you worked, a couple hours a day, maybe 6 months from now, maybe 8 months from now, you might be able to do the splits. What you've effectively done is you've lengthened your soft tissues without me. And you might have had to lengthen them an inch and a half, really,
Wow.
to get down to that position, right? Your hamstrings, your adductors, your hip flexors, you would have had to done that. And so soft tissue, just like gaining weight and gaining muscle, it's very plastic, right? It's very plastic. It has the ability to, to
Stretch.
change, stretch, change, stretch, it's may seem like boring tissue to most, but connective tissue actually has a lot of capacity to do a lot of interesting things.
The-
So
Yeah, my other question is just volume. Like, I know you said it's becoming more popular, and I'm not talking more individually or just, let's say in the United States, do you have a feeling on how often it's being performed at this point? I mean, is it thousands of cases, hundreds of cases?
I would probably say it makes it about 30 for this particular implant. I would say I think the last time I looked at, which was the 2024 data, I think it made up 13% of the volume of
Okay.
use of this particular implant, and there's only a handful of implants that we use. So it makes up about 13%, and so I would probably say it's probably in and about 1,000 procedures are done in the U.S., maybe
Okay. Yeah,
approximately.
that's helpful. And then
Yes.
one thing, and then I want Carl to finish up on the complications, but I just wanted to point out. So the reason this became a topic for me, first of all, I didn't know anything about it, so I'm really amazed by it. I guess I remember hearing about the other things that people were doing where they were kind of stretching, like crushing bone. And I mean, not quite as elegant as this by any stretch, by years ago. But I just wanted to point out, I don't know if you're aware of it, but there's a very popular movie that's out right now called Materialist. Have you heard of it?
Yeah, they interviewed me for it.
Oh yeah, it was. So I'm watching this movie on an airplane, and I was blown away. I mean, the
Yeah,
movies.
we were
Yeah,
just talking about. I was just talking to Carl about it. Like I was saying, did
yeah,
you see the movie The Materialist? And so they interviewed me for that movie like 2 years ago
that's
or
very
something.
interesting. Yeah, it
Yeah,
was really.
yeah.
But that's what happened. I watched a movie. I got home and I said, Carl, we really need to interview this guy. So because I just thought it was so intriguing that it was part of a mainstay movie, about a matchmaker. So it's
Yeah, no, yeah, no, we've had it, been featured like, like I was telling him, we were just on the front page of the LA Times, I think the
yeah,
beginning of this year. And, Kevin Hart invited me to his comedy show when he was here in
wow,
Vegas a few
that's
years ago,
interesting.
because he opens with a 4-minute bit about the procedure,
Oh
obviously
wow,
because he's short.
yeah,
So there's certainly in pop culture, I think there's been a lot that's out there.
yeah,
Um, I do think that, hence it's growing in popularity to some degree. Like you were kind of asking before, the growth, we see a double-digit growth when it comes to the
yeah.
cosmetic market. As the technology, I think, gets better as well. I think that number, just will continue to kind of keep compounding, getting bigger until it really, I believe, uh, dwarfs the pathology market, which is
Got it.
treating pathology. So kind of like similar to breast augmentation in some ways, right? Like
Yeah.
sort of like I don't know if you ever saw the movie Breast Men. Whenever it was David Schwimmer, but it's an old movie from the '90s. But when you look at the movie, you kind of think sort of similar in some ways, where he was at Baylor, I think, and they kicked him out because he started using reconstructive breast augmentations
I didn't
for
know that. Yeah.
non-cancer patients, and they thought, oh, it seems weird, and then kicked him out. But then in some ways he was right, and the procedure that's synonymous, at least culturally, with a plastic surgeon is really what is primarily used for cosmetics, right? So it's kind of an interesting
And
sort of thing. So we'll see what happens.
does insurance cover it?
From a cosmetic perspective, it does not. From a
So
pathology
it's got to be a
perspective,
medical. It's got to be a medical
correct.
indication. Yeah,
Yeah, and
medical indication.
it's rarely, if ever, bilateral is ever medical. Unilateral for sure, and we do a lot of unilateral cases, at least one a week. Um, that's the deformity, trauma, maybe a
Yeah.
pediatric thing that is left over, that sort of stuff. So yeah, so that still would be covered in the cosmetic realm, would not be so.
Kevin, if a complication that occurs the most, what is it and how do you deal with it?
Yeah, so we follow our cases pretty closely. I think, and we've got like a running kind of prospective database of our cases, and I think our complication in our office is probably a little over 3%, maybe a 3.3% or somewhere in that range. Currently, the largest complication is 50% of that number, or approximately 50% of that number, is nail breakage. So you can grab some nails here, but if you look at these implants, they're a telescopic rod. These are the ones I've taken out of patients because they're required to be taken out, but it's a telescopic device. They only currently, the current, which is one we're currently using on the market here in the US, is partial weight bearing. So one of the bigger complications I see is patients might overload the implant. It takes between 50 to 75 pounds per leg. So if they trip, stumble, fall, go up the stairs, do something too much, or do something too kind of against the protocol, or accidentally do it against the protocol, they have a risk of cracking the implant. If it does crack,
Wow.
generally the implant still works, to be honest, and it's still structurally intact. It's just that it may create a deformity potentially, and so then we advise them to take it out and replace it within your implant. That I think is for me the biggest complication I see, particularly in the cosmetic realm, because it's a bilateral case. It requires a lot of time. Remember, I said inch a month. So you're looking at like at least 2.5 months to get most goals, plus an additional 2 months for consolidation. So you're looking at almost 4.5, 5 months, maybe half a year of being cautious, right? Kind of is hard when a lot of these people are professionals. Maybe they go to school, maybe they're
Yeah, you gotta live
physicians,
their life.
they got to live their life. So, and they're generally pretty good, but sometimes things happen. They overdo something, they trip, they slip, something happens, and they create an injury, and then it needs to be replaced. Um, Other things, there's small things like, DVTs and other things that fall into that category. I usually put them on a blood thinner, post-op day one, and they kind of have to continue that the entire duration of lengthening. But a lot of the other things you can kind of prevent to some degree. And don't forget, you're lengthening very slowly, and it's a very good feedback with the patient. I generally see them every 2 weeks. We get some kind of feedback every 2 weeks. So you're really changing things at a very slow pace. So you're able to monitor. The nail's also bidirectional, so you can reverse it. You can really reverse it if you wanted to. Not that
Wow.
anyone would do that, but you could if you needed to. So, if you're watching close enough, then you can get patients to the other side pretty easily with the correct supervision.
Yeah, it's just very enlightening. Thanks so much. We really appreciate it. Glad we were able to get you. It's hard. And I don't know. I mean, I'm going to look more into this. I think Carl and I want to be taller. And I'm not too old. And I'm not too old, which is great.
Right.
No, yeah. So to be honest, like, yeah, I mean, I had a neurosurgeon I did last summer. We had a weight bearing nail that had just been released. He was back doing brain surgery within 2 weeks. I
Wow.
remember talking to him 2 weeks after surgery because he left early and he was in the Northeast. And I was like, hey, how you doing? He's like, oh, actually, Doc, yeah, I was on call for every day
Wow.
this week. And I'm like, oh my God.
He didn't want to listen. Doctors are the
Well,
worst.
yeah,
Doctors
no,
are the
doctors,
worst patients.
yeah, they're not very, they're good and bad in my experience.
Yeah.
And by the way, we have a lot of physicians to do this, and they're good and bad. They're good because they can, like, in a very succinct way, give me everything I want to know in like 10
Sure.
seconds, right? So they make the best patient when it comes to that. They're terrible at self-care though, somehow.
Yeah,
Like,
compliance is the worst.
oh, compliance is the worst. Yeah, they generally want to go back to work, almost immediately. They're going to tough it out, and they're going to put all the other stuff they want to do ahead of what we're doing here. Like, I rarely have physicians who do this stop working. Rarely. I had one ER doctor I can think of in my head that stopped. Most of them continue to work concurrently while doing it, especially with the newer technologies that are weight bearing. So, but a very we do get a lot of physicians. I will say that a lot of physicians,
That's wild. That's
attorneys,
wild.
people in software engineering.
So limb lengthening,
Yeah.
interesting topic. Thank you, Dr.
No
Debiparshad
problem.
in Las Vegas. If you're interested, please contact his office. If you found this helpful, please subscribe, like, share with your friends. Great seeing you, John.
Great seeing you.
We'll see you guys on the next one.
Thanks.
Thank you.
All right, guys.